Hello, this is Dr. Amy Tang. I am a primary care internist and director of viral hepatitis and TB programs at Northeast Medical Services in the San Francisco Bay Area. I will be presenting an updated guidance on hepatitis B management for the primary care provider. These are my disclosures. In this mini lecture, I will go over several topics, including some background on the primary care guidance and work group, hepatitis B testing and interpretation, and comprehensive management of the Hep B surface antigen positive patient. Primary care providers are at the front lines of screening, vaccination, chronic disease management, and care coordination. Communities most impacted by hepatitis B face barriers to accessing specialists, including cost, language, geography, and navigating a complex healthcare system. We know from federal level health center data that over 50,000 people with chronic hepatitis B receive their care from federally qualified health centers. Unfortunately, specialty guidelines on hepatitis B can be complex and may deter frontline primary care providers from providing this care. Thus, this primary care guidance was created out of a necessity to broaden the treating community to achieve hepatitis B elimination and address health disparities in liver cancer. The Hepatitis B Primary Care Workgroup, tasked with updating the guidance in 2025, consisted of a multidisciplinary panel of national experts in the field of viral hepatitis B. The workgroup included representation from primary care, hepatology, infectious disease, public health, including the CDC, and community coalitions, with geographical representation from Canada and across the United States. The workgroup partnered with University of Washington's CDC-funded Hepatitis B Online to host a downloadable hepatitis B guidance for primary care providers, first published in February 2020, and then updated in December 2025 with web and mobile versions, as well as a one-page summary. The guidance lays out hepatitis B provisions of care in primary care and specialty settings, including overlap in care that could occur in either setting or through shared management. Provisions of primary care include screening and vaccination, management of metabolic syndrome risk factors such as obesity, diabetes, hyperlipidemia, and hypertension, and the initial evaluation and counseling of patients that test Hep B surface antigen positive. Basic monitoring, such as twice-yearly hepatitis B labs and liver cancer surveillance ultrasounds, also fit in well with other chronic disease monitoring and cancer screening routinely done in the primary care setting. While hepatitis B and viral initiation and monitoring and hepatitis delta screening and follow-up testing may be less familiar to many primary care providers and non-specialists, the workgroup hopes through this guidance that more and more providers feel comfortable offering these services to patients with hepatitis B, particularly those who face barriers to seeing specialists. Strong indications for specialty referral of patients with hepatitis B include management of decompensated cirrhosis or hepatitis delta co-infection, concerns for antiviral resistance with persistent or increased viremia on treatment, persistent elevation of liver enzymes despite low hepatitis B viral load levels and lack of other identifiable cause, liver lesions on CT or MRI suspicious for liver cancer, or liver cancer evaluation and treatment. The guidance begins with the chronic hepatitis B management algorithm, starting at the point of screening and testing with the 3 hepatitis B serologies recommended by the CDC in order to identify markers of current or prior infection and immune control. Note that hepatitis B core antibody total, or IgG, is recommended for asymptomatic screening, whereas hepatitis B core IgM should be ordered when acute hepatitis B is a concern. Hepatitis B screening is recommended for all pregnant women, regardless of age, during each pregnancy, and all adults age 18 years and older, regardless of risk. Additionally, hepatitis B testing is recommended for persons with a risk of exposure at any age, particularly for persons susceptible to hepatitis B infection with risk of exposure since last testing. For persons who test Hep B surface antigen positive, this guidance will go over the recommended evaluation, counseling, management, treatment, and liver cancer surveillance. For persons who test Hep B surface antigen negative, management depends on the results of the other serologies. For example, if all 3 serologies are negative, indicating susceptibility to Hep B infection, then hepatitis B vaccination is generally recommended with one of the 2 or 3 dose vaccine series, depending on the age of the patient and vaccine availability. The 2-dose recombinant vaccine, also known as Heplisav-B, is FDA approved for adults aged 18 and older, including during pregnancy, whereas the 3-dose recombinant vaccines, such as Engerix-B and Recombavax-B, can be given at any age and during pregnancy. Note that the CDC recommends hepatitis B vaccination for all persons younger than 60 years of age and for adults 60 years and older with risk factors or those simply seeking protection. If hepatitis B surface antigen is negative but the core antibody is positive, this reflects prior infection, and patients should be counseled on their risk for hepatitis B reactivation or checked for occult hepatitis B with a follow-up hepatitis B viral load in patients who are immunosuppressed. Note that this guidance starts with the point of screening. However, for those practice settings where hepatitis B vaccination and screening are done together, we recommend blood draw before vaccination, or if vaccinated first, a delay in the Hep B surface antigen testing by greater than 4 weeks to avoid false positives. If Hep B surface antigen is positive, completion of the vaccine series is not needed. Interpretation of the 3 Hep B serologies can be challenging due to all of the possible result combinations. Perhaps the most common area of confusion is when patients test Hep B surface antigen negative and core antibody positive. In most cases, this reflects a history of hepatitis B infection. Patients should be counseled that the virus is dormant in their liver and can reactivate if they are on certain immunosuppressive medications in the future. Of note, this type of counseling is not dissimilar to how clinicians counsel patients on other infections, such as latent TB or vaccination for shingles. Patients who test negative for both Hep B surface antigen and core antibody, but positive for surface antibody, have never been infected and have antibody and immunity from prior vaccination. Longitudinal cohort studies in Alaskan Native populations have shown that this antibody protection is durable over decades, even when titers wane, and therefore Hep B booster vaccine is not routinely recommended. Lastly, if patients screen triple negative on their screening serologies, we recommend vaccination. However, there may be situations where the individual has documentation of full hepatitis B vaccination and has sub-threshold antibody levels upon screening. For persons considered low risk for Hep B infection, revaccination is not required. For persons at high risk for Hep B infection who previously received a complete vaccine series without follow-up serologic testing, acceptable management options include 1. Giving a booster vaccine dose followed by serologic testing 1 to 2 months later, with completion of the full vaccine series if the post-booster surface antibody test remains negative, or 2, give the full vaccine series followed by post-vaccination serologic testing 1 to 2 months after the last vaccine dose. Providers should consider the 2-dose Heplisav-B vaccine if the prior Hep B vaccine was a 3-dose series. The web and mobile versions of the guidance offer a new interactive component where providers can enter their patients' serology results and see tailored guidance. In the case of isolated positive hepatitis B core antibody, management depends on the patient's immune status. For immunocompromised patients, a follow-up hepatitis B viral load is recommended to evaluate for occult hepatitis B infection, which is managed similarly to patients who are Hep B surface antigen positive. Otherwise, the patient should be counseled on their prior infection and reactivation risk on select immunosuppressive medications. Patients prescribed medications deemed moderate to high risk for Hep B reactivation based on the American Gastroenterological Association's Hep B reactivation guidelines should be prescribed Hep B antiviral prophylaxis. The guidance organizes the initial evaluation of the Hep B surface antigen positive patient into 4 categories. During the history and exam, the clinician should note signs and symptoms of cirrhosis, alcohol and other metabolic risk factors, family history of liver cancer, and the patient's hepatitis A vaccination status. Routine lab tests such as a complete blood count and comprehensive metabolic panel are used to assess liver enzymes and liver function and can be used to calculate a FIB-4 or APRI score. An INR can also be ordered if cirrhosis is suspected. Under serology and virology, the workgroup recommends checking the patient's Hep B E antigen and E antibody status, as this can help to characterize the patient's phase of infection and eligibility for clinical trials. Acknowledging that it has been removed from the treatment algorithm in the simplified guidance, the American Association for Study of Liver Diseases still uses the Hep B E antigen to characterize the patient's phase of infection and treatment eligibility. All patients should get a Hep B DNA to evaluate for viremia and test for other viruses, including hepatitis A, total, or IgG, if Hep A vaccination was not documented, hepatitis C antibody, hepatitis delta, IgG, or total antibody, and HIV. If Hep C, Hep delta, or HIV screening tests are positive, then a follow-up viral load is needed to confirm an active infection prior to referral or offering of treatment. Lastly, all Hep B surface antigen positive patients should receive a baseline abdominal ultrasound and liver fibrosis assessment with elastography or serum-based assessments such as the APRI or FIB-4. When a patient tests positive for hepatitis B, the screening provider has an opportunity to educate the patient about hepatitis B infection, its complications, transmission risk, and ways to keep their liver healthy. Patients commonly ask questions about hepatitis B transmission, including how they may have gotten it and how they can prevent others from getting infected as well. It's important to emphasize the role of screening and vaccination of sexual and household contacts, family members, or injection partners, and to avoid stigmatizing language when discussing how hepatitis B can and cannot be transmitted. It is also important to emphasize that with proper monitoring and care, most people with hepatitis B can live long, healthy, and normal lives. When creating this guidance for primary care providers and non-specialists, the workgroup recognized that there are many hepatitis B guidelines with varying treatment recommendations. In principle, all Hep B surface antigen positive individuals with viremia are candidates for treatment. Factors to consider are fibrosis stage, Hep B DNA levels, ALT, risk of disease progression in hepatocellular carcinoma, and patient preference. Here we have outlined 4 indications for treatment of adolescents aged 12 years and older and adults with chronic Hep B. The first group are patients with a detectable viral load and significant fibrosis or cirrhosis, as demonstrated by a fibrosis score greater than 7 kPa on elastography or an APRI score greater than 0.5. The second group are patients with a viral load greater than 2,000 international units per mil and either an elevated ALT or a family history of liver cancer. The third group includes several subgroups, including 1, persons on immunosuppressive medications that pose moderate to high risk for Hep B reactivation. 2, persons with HIV, Hep delta co-infections or receiving Hep C treatment. 3, persons with Hep B vertical or horizontal transmission risk factors, including pregnant mothers with a viral load greater than 200,000 IU per mil, sexual or close contacts with someone who is non-immune or has unknown Hep B status or is immunocompromised, and healthcare workers doing high-risk exposure procedures. And 4, persons with extrahepatic manifestations of Hep B, such as glomerulonephritis, polyarteritis nodosa, and vasculitis. Lastly, any patient that prefers long-term treatment over a monitoring-only approach after a risks and benefits discussion may be prescribed antiviral treatment. Monitoring for chronic Hep B is similar for patients on and not on treatment. The basics include a Hep B viral load and ALT every 6 months, which may vary from 3 to 12 months depending on factors such as recent treatment initiation, liver enzyme levels, and viral load. If the patient's Hep B viral load is undetectable, a Hep B surface antigen should be checked annually to evaluate for Hep B surface antigen loss, which can occur in 1 to 2% of patients with chronic Hep B annually. Other labs such as an AST, platelet count, or elastography can be checked every 1 to 3 years to assess for liver fibrosis. Monitoring while on antiviral treatment is covered in the next section. The following table summarizes the key characteristics of the 3 preferred oral antiviral medications used to treat adults with chronic hepatitis B: entecavir, tenofovir disoproxyl fumarate, or TDF, and tenofovir alafenamide, or TAF. All 3 antivirals can be given once daily, with entecavir having a higher dose for patients with decompensated liver disease or prior lamivudine use. Entecavir is taken on an empty stomach 2 hours before or after food, TDF without regard to food, and TAF with food. Both TDF and TAF may be used during pregnancy based on data from HIV antiretroviral pregnancy registries, showing no increased risk of congenital anomalies when exposed in the first trimester, whereas there is insufficient data to support the use of entecavir during pregnancy. These medications are all well tolerated by most patients, with some variability in side effect profiles as listed. Clinicians should be aware that entecavir and tenofovir require dose adjustment when creatinine clearance is less than 50, and TAF should be avoided when creatinine clearance is less than 15 if the patient is not yet on hemodialysis. Patients on these antiviral medications should have serum creatinine monitored at least annually to monitor renal function and dose adjustment if needed. A bone density study should also be considered in patients at risk for osteopenia at baseline and during treatment with TDF. Persons with chronic hepatitis B at increased risk for liver cancer, specifically hepatocellular carcinoma, should receive routine surveillance, including after Hep B surface antigen loss. Persons with cirrhosis are at highest risk. However, unlike with hepatitis C virus, liver cancer can occur even in the absence of cirrhosis, including in men over 40 years of age, women over 50 years of age, persons with a family history of liver cancer, and persons with hepatitis delta virus or HIV co-infection. Liver cancer surveillance should be performed with liver ultrasound and serum alpha-fetoprotein every 6 months. More frequent monitoring or other imaging modalities such as CT or MRI with and without contrast may be indicated to further evaluate new lesions. Liver cancer surveillance can be stopped in persons with limited life expectancy or who would not tolerate cancer treatment if found. Those with observed Hep B surface antigen loss before age 50 and without cirrhosis are at lower risk for liver cancer and may stop routine surveillance. This guidance also covers the perinatal hepatitis B management workflow, which begins at the time of Hep B screening, with Hep B surface antigen at minimum, during each pregnancy and regardless of prior hepatitis B screening results. For patients who test Hep B surface antigen negative, checking a complete Hep B screening panel can help determine if the patient is susceptible to Hep B infection and may benefit from Hep B vaccine during or after pregnancy. Engerix B, Recombavax, HB, Heplisat B, and Twinrix are all safe to administer at any time during pregnancy. However, Heplisat and Twinrix are approved for use among those aged 18 years and older. All infants born to Hep B surface antigen negative women are recommended a first dose of Hep B vaccine within 24 hours of birth and to complete the vaccine series on schedule. Whereas infants born to Hep B surface antigen positive women should receive their first dose of Hep B vaccine and the Hep B immune globulin, or HBIG, within 12 hours of birth, and have a post-vaccination serology test performed between 9 and 12 months of age after completing their vaccine series to assess for mother-to-child transmission and confirm immunity. Pregnant patients who test Hep B surface antigen positive should also be counseled on the importance of household contacts and sexual contact screening for hepatitis B and regular follow-up during and after the pregnancy so that appropriate Hep B monitoring can occur, especially since the postpartum period is a time of increased risk for Hep B flares. For patients who meet long-term treatment indications during or before pregnancy, tenofovir can be safely continued or initiated at any time during pregnancy for the health of the mother. Patients on entecavir at the time of pregnancy diagnosis should be switched to tenofovir. For patients not on antiviral and without elevated liver enzymes, The Hep B viral load should be checked before 28 weeks pregnancy to determine the risk for mother-to-child transmission. If the Hep B DNA level is greater than 200,000 international units per mil, the mother should be initiated on either tenofovir disoproxil fumarate or tenofovir alafenamide at 28 weeks gestation or earlier. The antiviral can be stopped at the time of birth with close monitoring for ALT flares, at least every 3 months for 6 months. Hep B surface antigen mothers, including those on antiviral, should be educated on the value and safety of breastfeeding and that hepatitis B is not transmitted through breast milk. Breastfeeding mothers with cracked nipples should practice proper nipple care and be informed that infant receipt of Hep B vaccination and Hep B immune globulin will protect against Hep B acquisition from such exposures. Lastly, in response to requests for a one-page summary, our work group has created this one-pager on the basics of hepatitis B screening, vaccination, evaluation, treatment, and monitoring as a convenient reference for the busy clinician. For more detailed information on these topics, including perinatal hepatitis B management, please refer to the full guidance. Thank you.
The production of this Hepatitis B Online mini-lecture was supported by funding from the Centers for Disease Control and Prevention.